Thank you for that lovely introduction. Today I'll be presenting a case of septic prostatitis in a neutered male dog and discuss how mechanical obstruction can actually override the hormonal protection that we sometimes see in a canine prostate post-neuter. Our patient that we'll be discussing today is a 1.5-year-old male neutered English bulldog. This patient presented to the KUHA ER service with a presenting complaint of vomiting, straining to urinate and defecate, as well as an appetence. He does have a pertinent medical history of 1 year prior to presentation to the ER of a urethral resection due to prolapse. Additionally, 8 months prior to presentation to the ER, he had a second urethral prolapse that resulted in a urethral resection, an anastomosis revision, a urethropexy, as well as a pre-scrotal castration. On presentation, the patient was quite tachypnic, tachycardic, and had a BCS of 9 out of 9. Typical, some may not be surprised. On physical exam, on abdominal palpation, he was quite painful and responsive and really resistant to the palpation and had a painful and distended bladder that was felt. He was also moderately dehydrated as well. Because of this, we began our initial diagnostics. So just going through some of the blood work that we did, I want to draw your attention to some of these values. The first thing I want to talk about was his metabolic acidosis with respiratory compensation, and he had a pH of 7.429. He also had a very severe azotemia with a BUN of 129 and a creatinine of 11. He was also markedly hyperkalemic and had a left shift with marked toxic neutrophil changes. Lastly, he was also severely thrombocytopenic and had a suggestive situation of consumption or an immune-mediated destruction. Overall, together, these findings are insinuating a strong inflammatory response and cause concern for a situation such as sepsis or endotoxemia. Moving forward after those initial diagnostics and emergency stabilization, we began to see what the problem was being caused by. The first thing that we did were some abdominal radiographs. So just to orient you, this is a right lateral radiograph with the head on your left and the tail on your right. Some of the key things I want to take your attention to are here with the white star looking at the ventral abdomen and a soft tissue opacity structure. This is a moderately distended urinary bladder, and it is quite large. Additionally, caudal dorsal to it, we see another soft tissue opacity in the location of the prostate. So we have a diffuse moderate prostatomegaly as well. And lastly, in this image, I want to show you the wispiness that was in the ventral abdomen, which is showing a small to medium volume peritoneal effusion. Moving forward, we did a VD image as well. In drawing your attention here to the pelvic region, we look particularly where this white arrow is pointing, and we see a medium-sized foci of a urinary calculus in the pelvic urethra. So next we move forward with our urogenital workup. So the first video that you're seeing here is of the prostate. And you may notice the irregular margins of the prostate. It is quite bumpy and lumpy, and unlike the smooth margins that we typically see. Additionally, we also notice a heterogeneous appearance to it as well that is not typical of a normal prostate. And there are some few small mineral foci that are scattered within the parenchyma. Additionally, not pictured in this loop in particular, we saw a heterogeneous hypoechoic focal structure in the dorsal aspect of the prostate that was consistent with either a cystic or abscess process within the prostate as well. Because of this, we began looking further into our urogenital structures. Next, we looked at the kidneys. And so this is the left kidney, and using this as a representation for both kidneys since it was a bilateral process. We saw a moderate diffusely enlarged kidney on both sides, as well as the renal pelvis that you see pictured here, being moderately distended and having an anechoic fluid. Additionally, around the kidney, we see a perirenal fluid that could be suggestive of an obstructive process, an inflammatory process, or a pyelonephritis as well. So overall with this, we now know that there is additionally a mild bilateral renomegaly with pylectasia. So next we chose to look at our urinary bladder as well. And it is quite large, as you can see it taking up most of the abdominal image here. So we saw a moderately distended bladder with echogenic debris, as well as a mild diffuse wall thickening that is most apparent here on the dorsal aspect. And you can see the shadowing as well as the thickened appearance as well of this bladder. Additionally, floating throughout the bladder, you might see as well this mild, moderate echogenic debris floating around. So we now have a mild cystopathy as well, with moderate urinary debris, as well as this pelvic urethra calculi that we saw in the prior radiograph. So overall, in the big picture here, we now know we are seeing a urinary obstruction that is leading to not only a cystitis, but also a pylectasia and kidney enlargement as well. Next, because of the ultrasound findings, we pursued a fine needle aspiration of the prostate. So here you're seeing a ultrasound image of that needle entering the prostate. And on the right-hand side, you will see our cytology from this fine needle aspiration. It was really interesting to see the cytology because as you see through the image, we see an abundance of nuclear streaming. And in the center here, you can see the intracellular bacteria or the cocci that we found throughout this cytology of the prostate. So now we are seeing a septic suppurative inflammation with cocci bacteria from the prostate. So we then also did a urinary collection while we were in the ultrasound and found a Staphylococcus pseudointermedius as well in this urine. Because of these findings, we chose to take this patient to surgery. So overall, the surgical intervention consumed a cytology, a cystotomy, a urethrostomy, as well as a biopsy and cytology of the sample from the prostate. Following surgery, he was discharged after stabilization on antibiotics and treated for this prostatitis. So looking at this histopathology from the prostatic tissue, zoomed into 100x, we can see a large number of granulation tissue bed and infiltrated by a large number of neutrophils throughout this sample. And this was also compatible with the clinical diagnosis of prostatitis. So what does this mean for us? So looking at the classical teaching of the prostatitis in a dog, we typically see it in an older, intact male dog. And this is due to the androgen stimulation. Normally, the androgen stimulation leads to a duct dilation and impaired prostatic secretions. Because of this, it is an altered local immune defense system, then leading to the ability for ascending bacterial infection in the glandular acini and the ducts. And this results in the overall infection that we see in a prostatitis. But let's remember, our patient is castrated. So then why did this patient develop prostatitis? In this case, our theory is that he had a localized UTI that was already occurring due to the fact that he did have some issues with his urethra prior diagnostically indicated about a year prior to the presentation. So from the cystitis, a then urinary obstruction occurred in that urethra, and it was basically a cascade of events from there. The obstruction then led to the urinary stasis, allowing for bacterial proliferation, an ascending bacterial infection, prostatic duct colonization, and then the prostatomegaly that we saw. So just to summarize overall how these events occurred and how everything is related. We saw this pelvic urethral obstruction, which then led to a cystitis, a prostatitis, a pyelonephritis, and a septic abdomen due to the bacterial translocation. So just to round it out and talk about why this case is so important to us as a whole. When looking at this case, it is a reminder that although this is not a common pathophysiology post-neuter, it should be on our differential list in any dog that has an abnormal prostate as well as abnormal urinary status. And that prostatic disease is still possible post-neuter. And it is always fun to, of course, find the zebra within the herd of horses. Overall, I want to thank Dr. Mariana Dale de Amorum and Dr. Chris Tollefson for giving me the opportunity to be involved in this case and getting a lot of imagery exposure, and also to the group here as SFT and allowing me to present this case to you guys. And at this time, I'll take any questions.